So it's great to finally be here. As Paul said, it's been a few years in the making, to chat to you about a topic that is often not talked about or often not even thought about. It's also a topic that tends to stump people, and is sometimes a conversation killer. Friends have asked me why I would embark on a topic where each subject in isolation is hard and melancholy. So bringing the two fields together is something that's kind of a bit nuts. Palliative care colleagues are fascinated though, and they ask, but why isn't it already happening? And humanitarian colleagues are fascinated and raise the question, but how? So it's my hope that in my short time here in Baltimore, I can help to spark hopefully some new conversations and generate some new seeds of ideas for ways forward for dialogue, research and practice on palliative care and humanitarian crises. And I think that there's nothing more of a privilege than being given permission to walk beside somebody along their illness journey and with their families, and to be with them as they take their last breaths. And no more so when they live under the kinds of extreme circumstances that we're talking about here. So I'm going to share a little bit of background to the topic, some broad definitions, some current challenges and what's already happening in this space globally. And I then want to share a snapshot of stories from my recent research on palliative care in the Gaza Strip in Palestine. And I want to finish by highlighting some ideas for the future that hopefully we can have some time to discuss. I want to start though, if I can get this. Oh, of course it was working before. What's that? Oh. Excellent. I want to start though with the land acknowledgement. In Australia, we call this an acknowledgement of country, and it's something that's become really integral to the way we think about our place on the lands in which we meet, work and play. So I want to gratefully acknowledge the native peoples, the Piscataway Indian Nation and the Susquehannock, I've got that right, Indians on whose ancestral homelands we gather today. I also want to acknowledge and express my gratitude to the Wurundjeri and Dja Dja Wurrung people of the Coghlan Nation in Australia, on whose country my recent research was conceived and written. And I extend this gratitude equally to all Palestinian people of Gaza, on whose lands and by whose seas this research was carried out. I acknowledge that my research with them is at its heart about sharing their stories and raising the voices of Gazan people affected by serious illness and all those who seek to help them. I am indebted to Indigenous people in all these places for the reminder that dispossession of country and waters is no match for their extraordinary endurance and resistance. So I want to start by sharing a story that early in my studies formation, I had a conversation with an experienced humanitarian practitioner. And I asked her, what does palliative care in humanitarian crisis look like to you? And she deliberated for a bit before she offered this story. I haven't thought about palliative care in crisis before, but let me tell you this story, and it's a story that will never leave me. Last year, I travelled to Somalia with an international humanitarian organisation, and I visited a hospital caring for malnourished children. I was taken to a room where a young girl lay on a bare table. The girl was screaming in pain, crying out for her father. She had a very visibly swollen and red-hot groin, having endured female genital mutilation some days before. And her entire body was also in tonic spasms. She was suffering from tetanus as a result of the dirty implement used to perform the FGM. And she was in absolute agony, but there was no pain or symptom relief in sight. And her father stood in distress by her side, lifting her up in an attempt to ease her pain each time she screamed, "Papa." I learned that the girl was 10 years old, the same age as my daughter at home. I went close to the girl as she screamed, leant over to her, touched her hand and whispered gently in her ear, a simple but soothing shh, shh. The girl immediately stopped her crying and turned her head towards the sound, searching for my face. And her body relaxed, and for some moments she became still and calm, seemingly comforted, if only fleetingly, by my warm touch and my soft voice. We left shortly after, and I later heard that the young girl died the next day. So I presented this story to audiences shortly after she told me this on 2 separate occasions. Following the first, a well-respected palliative care practitioner appeared really upset and affronted with the notion that the act of comforting in the total absence of medical intervention might be considered a type of palliative care. What would you do in this scenario? I asked him. I would just get the morphine in. I'd smuggle it in if I had to, he replied. And he was, of course, quite nobly challenging the law in his firm conviction of what is needed to relieve suffering. Of course, she needed antitoxins and pain relief. But he was also challenging a conception of palliative care outside a biomedical frame. Following the second occasion, a well-respected humanitarian practitioner was due to present her own paper. As she stood up to begin, she shook with tears and instead left the room. Later, she confided to me that her mother with end-stage dementia lived in an aged care facility, and at each visit, she would sit quietly beside her mother, stroking her hand and calming her with a soothing voice. And this woman had felt so moved by and felt so connected with the idea that she was helping to provide palliative care to her mother through the acts of comfort and presence. And she thanked me for a story which had given her permission to hug and humanize her mother. It had also, she said, given her permission to grieve. So the heartbreaking story of the Somalian girl and the passionate and very diverse reactions to it sparked for me a thorny question to a wicked problem that set the tone for my explorations for the beginning. What does care for those who are seriously ill and dying look like across settings and cultures, particularly in crises where resources are finite, suffering may be extreme, and caring does not always look the same? So what do we mean by palliative care? Palliative care involves the support, physical, psychological, social, and spiritual, of those who are seriously ill and dying, and bereavement care for after a person has died. It seeks to ease suffering and focuses on living life with quality, regardless of whether a cure is available. The origins of palliative care go back centuries. In medieval times, for example, passing travellers who fell ill could find refuge in monastery hospices and be attended to clergy until death. Historically, illness, dying, and death were always part of family and community. The home was where families supported the dying, death happened, bodies were prepared, funerals took place, and families comforted the bereaved. Modern palliative care, though, grew as a concept and then a medical specialisation in the second half of the 20th century. First recognised as a specialist discipline in the United Kingdom in the late 1980s, taking up its home within Western healthcare organisations and systems, and now a field of medical specialisation in a growing number of countries. And this is the most globally accepted definition of palliative care from 2002 from the World Health Organization, an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. With the emergence of palliative care as a medical specialty and the growth of modern medicine, the process of dying has been transformed, shifting from a spiritual and a relational process to a medically and a professionally managed one, where we see illness, aging, dying, and caring transferred from homes and communities to institutions and healthcare systems. And in response, we're seeing the advent of new alliances, compassionate communities, death cafes, boutique hipster funeral parlours, motivated to recreate communities comfortable with talking about death and to reinvigorate community networks of caring. Today, we see palliative care presented as both a medical and a professional specialty and a social movement come almost full circle, where dying is demedicalised, everyone's business, a social event with a medical component and not a medical event with a social component. There's a growing movement towards a public health palliative care, which places the broad networks of community at the centre and recognises the social, political and economic worlds in which people get sick, live and die. Across the world though, access to palliative care and the experience of dying is inequitable and paradoxical. While many people are overtreated in hospitals with families and communities relegated to the margins, still more remain undertreated, dying of preventable conditions and without access to basic pain relief. Only 0.03% of the world's opioids are distributed to low-income countries, often used as a proxy measure for palliative care availability. Definitional debates abound. At its most broadly defined, though, palliative care is now seen as something for all chronic conditions, not just for cancer, has no time or prognostic limits, so it's not just for end-of-life care, is practiced by all health and social care professionals, not just specialists, and can be provided in any setting, including in the home. It includes, but isn't limited to, pain and symptom relief. And we see emerging efforts in countries, even with strong palliative care specialist systems, to integrate basic palliative care across primary health, aged care, and disability. And I tell you this because I think it all holds relevance for how we might view or explore palliative care in humanitarian contexts, where often no or only fledgling formal palliative care exists, and where community care systems are still the mainstay of reaching people in need. So palliative care and humanitarian response then share common ends. Both make claims about the need to alleviate suffering and of the dignity of human life, and both hold an ethical root in recognition of our universal suffering in illness and dying. As you would all know, the overall goal of humanitarian action is expressed as humanity, to protect life and health and alleviate suffering wherever it may be found. In many ways, the central aims of palliative care have featured throughout the history of humanitarian action. In a modern take, I think Hugo Slim sums it up beautifully when he says, "The ground of ethics in humanitarian action is a profound feeling of compassion and responsibility towards others who are suffering, who are living and suffering in extremis. It is a feeling of identification and sympathy that demands some reasonable and effective action as a response to suffering. Humanitarian feeling can be born out of a warm glow or a cold shiver. It may burst from the chill horror at outrageous cruelty and a strong passion to stop it, or it may spring from the depths of love and a burning desire to care for someone. It may arise between the two in a sense of sadness at suffering and a desire to encourage and to build up." Many of those who work in palliative care would lay claim to providing such compassion and connection at a time when suffering is at its most extreme. Palliative care is in many ways a reminder of why we are there, not only to save lives, but to compassionately care. Despite the parallel claims and ethos, addressing the suffering of people affected by serious illness and dying, events in humanitarian contexts, which are events we know are marked by high mortality, has received triflingly little attention alongside the imperative to save lives. In many ways, debates within palliative care mirror debates within humanitarian response, expanding and contracting definitions around emergency versus chronic care, the blurry demarcation between humanitarian and development efforts in the long durée of protracted crisis and complex crises, and a return to local ways of being and doing embedded in community. Palliative care puts into stark focus humanitarian considerations of localisation and the humanitarian development nexus. So who needs it? Several literature sources have attempted to classify the very broad range of people needing palliative care in crises. In my Gaza research, for example, some participants applied palliative care only to cancer, and particularly end-stage disease. It was more broadly applied, though, also as necessary for people with both acute and chronic injuries sustained in warfare, for older people, and for those with a whole raft of chronic illnesses, such as renal disease, stroke, cardiovascular disease, diabetes, COPD, to name a few, and genetic and metabolic conditions in children. Positively, there's momentum building in this space. Until recently, discussion in the literature really centred on sudden onset crises and mass casualty events, in which resource rationing and triage become paramount, and where serious ethical dilemmas have been raised. For example, who gets evacuated first, or who gets the last ventilator or the last vial of morphine? In emerging research, though, there are increasing efforts to understand all those requiring palliative care in crisis, with a shift towards stable refugee settings, and particularly on the moral experiences of healthcare workers. Palliative care is beginning to appear in global guidelines and training, and here's a list of some of them, which I won't go through, but I'm happy to speak in more detail later. A Lancet Commission on Palliative Care and Pain Relief devised a new framework to measure the global burden of serious health-related suffering, that associated with disease or injury which can't be relieved without medicine and compromises physical, social, and emotional function. And this commission determined that most of the burden of serious health-related suffering can be relieved through an essential package of palliative care and pain relief. One of the clearest entreaties is that immediate release morphine be made available in all countries. And there are organisations advocating for legislations and policies towards equitable drug systems that balance overconsumption and non-medical use of opioids with underconsumption. And the Palliative Care and Humanitarian Aid Situations and Emergencies Network, PALCHASE, is a growing network of loose individuals dedicated to seeing this topic get the attention it deserves. And yet, there remains no evidence of uptake or practical testing of any of these guidelines or packages. There remains limited empirical research or practice-driven publications, particularly concerning conflict and more complex humanitarian crises. Training for healthcare workers is increasing, but tends to come in the form of online didactic training. And leadership tends to arise from palliative care practitioners with a distinct lack of dialogue from humanitarian agencies. COVID-19 was a huge missed opportunity. It led to an abrupt explosion of working groups, commentary, clinical guidance, and research studies concerning the links between palliative care and crisis. And it should have been the impetus to get palliative care more firmly on the global humanitarian agenda. And yet there's been continued omission of palliative care from COVID-19 humanitarian guidelines, where the focus has remained on mitigation and treatment, even through tragic suffering and death. So why has it been so neglected in humanitarian consciousness? Here are some findings summarised from the literature, and then I'll take you through mine in relation to the findings from the Gaza research. So first, palliative care is beyond the convention of humanitarian practice. Medical science's preoccupation with curing, saving, and prolonging lives relegates those historic efforts to palliate suffering. It plays out in global health metrics, such as mortality rates, and in fundraising efforts by humanitarian agencies. Supporting someone to die or caring for an older person as they decline simply do not appeal to public sentiment. Secondly, it's beyond the capacity of humanitarian resources and systems. Triage practices focus little on what to do for those who will die despite best efforts or who are relegated to die by triage. The limits of material and human resources are major impediments. While there might be strong ethical arguments for the inclusion of palliative care, how it actually gets implemented is an unresolved tension. Then it's beyond the competence of humanitarian actors, and there are a lack of policies, guidelines, training, and expertise to support them to integrate palliative care into their work. And I would say this is the area that's currently receiving the most global attention. And finally, attempts at bringing palliative care into humanitarian response lacks consideration of cultural, societal, political, and contextual values and differences. And I would say this is the area probably receiving the least attention. So this is Gaza's little slice of the Mediterranean on a quiet day from my apartment window. Gaza is a setting of protracted crisis and health injustices overlaid with waves of acute and brutal warfare, as well as intense internal political divisions. And I was in Gaza conducting palliative care research in February, March 2020. I held 58 interviews with participants spanning healthcare actors working with humanitarian organisations and the government healthcare system, and patients, family caregivers, and bereaved family members. As one of the first and largest empirical topics, the studies on the topic, my research questions were deliberately broad. I didn't set out to measure existing palliative care through commonly applied instruments. Instead, I sought to explore how illness, suffering is understood and care for the seriously ill and dying in Gaza is currently enacted, and to seek the views from Gazans on what a palliative care future might look like for them. So I want to share 3 groups of stories and then propose 3 things to think about for palliative care and humanitarian crisis that stems from this research. The first group of stories concerns the backdrop of social and political circumstances and their relationship with illness-related suffering. Political challenges are often a postscript, too wicked and beyond humanitarian remit or individual health interventions to tackle. Yet when the participants I spoke with were asked directly about illness-related suffering and illness experience, every single one very quickly widened the discussion to political and related social and economic issues, entirely outside a medical or a health frame. They spoke of the inseparability of extreme poverty, the impacts of brutal warfare, and denials of the right to access healthcare on their experiences of illness and caring. Biggest challenges for patients, said one healthcare worker: poverty, siege, poverty. And another illustrated, and this woman with diabetes was sitting in her wheelchair. The door was knocking. Doctor, doctor, come, come. What happened? What happened? She was gasping. Gasping from her poverty, gasping from her low economic status, gasping just because she is Palestinian and she can't reach and cross the borders to reach improved care in maybe West Bank and Israel. She's gasping. The accumulated exposure of Gazans to life under poverty, violence, and health rights violations led to a suffering that was not individually illness-focused, but to a collective suffering. It's hard and even considered less important by some to see the individual sick person amidst the collective. And the role of the healthcare professional trained in individualised medical care also then reaches its limits. The second group of stories concerns the challenges and assets to caring in illness and dying. In serious illness, Gazans place comfort and accompaniment in the hands of family and community, fate, destiny, and hope in the hands of God, and biomedical care in the hands of healthcare workers. In the healthcare system, an acute, emergency-focused, life-saving and curative characteristic certainly does play out. And there's a paradox between saving lives at all costs and ceasing care or giving up when a patient is dying. It's tied up in a culture of increasing medicalisation, short-term humanitarian project cycles and funding, and severe healthcare resource limitations that do not allow for resources to be directed to those with chronic illness, to older people, to those with long-term disabilities, or to those who are dying, particularly through the accumulation of traumatic injuries through waves of acute warfare. Defining healthcare priorities runs counter to localisation, and humanitarian and development silos contradict the longer-term needs of those with serious illness. These challenges mean that those with chronic or terminal illness fall through the gaps, and healthcare workers feel powerless in their capacity to provide care. There are few opportunities for support and self-care. I'm going to read you the story of one healthcare worker, which really summarises what all healthcare workers were feeling in response to the need to provide care for those who are seriously ill and dying. There is a physical burden, a mental burden. Everybody you can imagine is tired, and emotionally wise, no one is taking care of you. Even no one can address that I'm emotionally not fit to do this. I need a break. In one duty, I had 10 patients in the paediatric ICU, and when I arrived at my shift, 2 cases had already undergone many CPRs. I was informed that don't do anything, they will die anyway. And then these 2 cases died during my shift. Then I received another case, which was a drowning from a pool, and she arrived in her late stage and she died in my shift. And another baby who had been there for 6 weeks decided to die on my shift. Can you imagine me in 12 hours? I have 4 deaths in my ward. How should I feel? Even it was a joke that it had never happened, that 4 cases died in one shift for a doctor. Are you working with the devil or something? They said. No one said a good word to support me. I was devastated. I went home to cry for hours. And then the next day I came back to have another shift, to have other babies to serve. And no one would take care of your spiritual or your psychological aspects. No one would say, thank you, you did a great job. Or you've been in a bad situation that really you need a break. I cannot remember that I've had any annual leave. I'm not allowed to go outside Gaza. You are in constant pressure of the Gazan situation. I try to have a long walk by the beach. I go to the gym to use this energy. Sometimes I dance in my room. I want to take it off. Sometimes I feel I'm like a machine. I feel like a robot. I feel like I'm doing things according to the protocol and I'm not listening to my spirit. And then I feel like, no, I have to focus. There are other kids. They need me more. And this baby has already died and I did everything. I couldn't save him. And even for his family, if I am empathic with his parent, they will see the tears in my eyes. And I cannot go so deep for this pathway. I cannot get emotional because I have other duties to do. The bulk of caring in serious illness and dying then falls to family and community. People with serious illness are usually cared for and will die at home, and bereavement happens in the home, surrounded by family. Religion plays a central role in making meaning of and mitigating suffering. And there is an Arabic proverb, a paradise without people is not worth setting foot in. Relationships in illness, dying and caring are treasured above all else. Palliative care, as at its most basic, is felt to already exist in family and community ways of caring. One participant reflected, we are a community who are helping one another. Even without any formal support, palliative care could be provided directly by the family. Family members, they come together, they stay, they help, or even neighbours. This is the society. Though they are not naming it palliative care, it is some sort of care. For many participants, a future for palliative care is to be found in a system which does not seek to replace, but rather supports these assets through a sharing of responsibility between family, community, and the healthcare system. Palliative care should be involved with everyone in the street, said one, and several called for community forums to deliberate ideas on the future of palliative care. So then the third group of stories concerns current conceptions of palliative care and what actually matters most. Small but important advances in palliative care are happening in Gaza, but it was acknowledged that many of the current ideas, training and support have arisen from expatriate and mainly Western specialists. Some spoke within a frame of palliative care as a specialist, professionalised, and therefore needing expensive inpatient hospital or hospice care, a palliative care that they found easier to describe and count, based on the transfer of knowledge from outside and carrying an implicit assumption that palliative care scarcely exists unless designated a medical specialty. But probe deeper, this type of specialist and professionalised care doesn't match with what people say is most important. All healthcare workers were seen to need basic skills in physical, psychological, social, spiritual, and bereavement care, and felt palliative care should be mainstreamed across care settings. Use of terminology matters. Palliative care was understood as existing in everyday caring practices akin to the care already offered to those with serious injury, chronic illness, or in rehabilitation, even if they didn't name it as such. A lot of what I do is palliative care, a lot of it, said one healthcare worker. Then the way in which care is practiced through humanistic caring seemed to matter most. Palliative care was used as a synonym for compassionate care. The relief of psychological suffering translated to small acts of compassion, smiles, nature, touch, having the presence and attention of someone who cares. The simplest thing that we can provide, even if we don't have the capacity or the means to offer anything else, the simplest thing is to be compassionate with your patients. But poor communication and lack of compassion arise against the backdrop of crisis, and it's hardly surprising that healthcare actors will omit attention to these softer caring aspects. This is a healthcare worker's story. I think his name was Sammy, 21 years old. He was complaining of a gunshot directed to his airway. Sammy had a lot of blood coming from his airway. When you look at their eyes, you see something strange. I think also in emergencies, we make palliative care, you know. We are caring for a patient's feelings, but it's not protocol. There is no protocol in how to deal in palliative care for patients with injuries. But maybe we did it, even if we don't know how to make it, just to exchange a feeling with the injured. So, 3 things to think about. First, we need to find the right balance between a Western specialisation and professionalisation of palliative care with compassionate caring by all. The prevailing modern and mainly Western palliative care narrative presents palliative care as a medical specialisation. If viewed through such a lens, palliative care will always be seen as a resource-intensive luxury, benefiting a small minority and not reaching all those in need. We need to find a balance between focusing on specialist skills with basic palliative care skills for all healthcare professionals. And there are enormous opportunities to consider basic palliative care approaches across a whole range of existing sectors: ageing, rehabilitation, primary care, paediatrics, grief and bereavement within existing mental health and psychosocial care, existing home-based care. And critically, we need to ensure these things are properly balanced with humanistic caring. Healthcare actors may need instruction in humanistic skills. They may need opportunities for self-care and for sharing experiences to navigate their challenging and distressing environments. Second, we need to harness the community assets that are so integral to culture, norms and caring. The prevailing modern palliative care narrative also starts from a place of what doesn't exist. What are the deficits? To not preserve family and community as the bedrock of caring systems in any paradigm of humanitarian palliative care would be reckless. We need to harness, not detract, from these family and community relationships and make more concerted efforts to strengthen connections across health and community networks, schools, places of religion, workplaces, community clubs, an area increasingly being paid attention to in many rich country contexts where we've come full circle. The community assets in Gaza are already there for those who wish to see them. There's an important correlation between the emerging public health palliative care discourse and current humanitarian localisation discussions. Could we consider palliative care as a relevant case study for localisation that draws on community assets, brings together disparate community networks, and bridges the humanitarian development divide? And then third, I think we need to understand how the prevailing modern palliative care narrative is altered by socio-political circumstance The entire premise of modern palliative care is one built on peace and spiritual calm. But humanitarian palliative care is clearly not synonymous with peace and calm. Finding such harm and healing when living through collective suffering and acute and pervasive stresses is a near impossible business. So what are the alterations to this peaceful life palliative care that shift how it is conceived of and enacted in settings of violence, war, and political obstruction? We need to understand how this changes the palliative care framework that is needed across vastly different contexts through very localised research and projects, an area I think that is very little explored. I'll just briefly give you an illustration to try and sum all this up. The new Essentials for Palliative Care is a public health framework that does try to bring together all of these contributions of specialist, basic or generalist palliative care, the communities and neighbourhoods, and the broader networks of civic institutions. And these domains will articulate differently in every context and every society. In most Western healthcare systems, the mechanisms are already in place, or at least are emerging, to connect the specialist, that's the blue cog, and the basic or the generalist palliative care, the bright green cog. In Gaza, of course, these two domains are pretty woolly. Unlike most Western contexts, though, Gaza has this teal-coloured cog, the compassionate communities, pretty well sorted. Gaza also has an enormous array of civic institutions, the red cog, to draw from, though it currently includes a bewildering and a fluctuating number of humanitarian and community-based NGOs whose engagement does tend to target individuals or disease-specific activities. Forging better connections between these networks, already present in abundance in Gaza's community life, could go a long way to ensuring those with serious illness are well taken care of. Every context needs its own balance of these cogs fit for that context, their own palliative care paradigm. So trying to bring all of that together in some kind of coherent what next statement that has real world application and can be achieved in the next 3 months. This slide is it. I think we need humanitarian sector leadership and dialogue on prioritising palliative care. We also need to have humility, though, that not all suffering can be mended, and life-saving care is, of course, important. The dialogue has to be honest. We could be adding our voices to the work of those in global palliative care, already advocating for equitable and balanced opioid policies and working to combat opiophobia in humanitarian contexts. We need locally led research and programming application across different types of humanitarian settings. We need to understand how war and complex emergency change meanings of suffering and care approaches across contexts. We need to change our frame of thinking towards a better balance between specialist and public health palliative care and create dialogue and demand with communities at the same time as we work with healthcare workers and systems so that palliative care really can be involved with everyone on the street. And we need to think of all those who would benefit from palliative care across sectors, diseases, and settings of care. There are many intersections for palliative care within existing areas of work. We need to reach out to those agencies that already work in these areas and work with them to deliberately bring palliative care into focus. And we need to consider how these intersections fit with localisation and the humanitarian development nexus. And then finally, we need to recognise that palliative care can't be delivered in a vacuum without caring healthcare workers. We need to ensure we are supporting healthcare workers to deliver care well. I just want to finish with a final personal story from Gaza, and then we can have some discussion, hopefully. In 2020, I visited an Australian lady who was living and working in Gaza. Jean had been living in Gaza for some decades, the founder of a college for people with disabilities within the Palestinian Red Crescent movement, a mother to 3 adopted adult Palestinian children, all with disabilities, and a sister and a mother to many more. Jean thought the palliative care research was incredibly important and helped me to set up some interviews with her healthcare colleagues. She bought me lunch and I brought her Australian Vegemite. When I next visited Jean in December 2022, I heard she was very unwell and was invited to visit her in hospital. When I arrived, she was screaming out in physical pain. I do not know that she recognised me. She was actively dying. That morning, she had a central line inserted to give her intravenous antibiotics. She had last had a paracetamol 3 days earlier. While I was there, she was taken down for an X-ray to check the central line placement, moved from the bed to a stretcher, further exacerbating her pain and her screaming. It was deeply confronting and challenging, and every fibre of my being had wanted to plead to stop the antibiotics, stop the interventions, and as my colleague had said, just get the morphine in. I gently suggested to the medical team that they might give some pain relief now. Then her daughter arrived and entered the room, and I watched her move to Jean, her mother, quietly say, "Hello, mummy," and stroke her dishevelled hair. The screaming stopped. Jean opened her eyes and became calm. Her daughter wet her lips with ice. It was a moment just as my colleague had described with the Somalian girl, deeply affecting and a little bit traumatic. Jean died 4 hours later with a little bit of pain relief in her drip and her daughter by her side. Amidst the omnipresence of resource scarcity, violence, injustices and death, I think we need to find all the things that ultimately make it fine to die, gracefully and with dignity. And I leave you with this poem excerpt by the late Palestinian poet Mourid Barghouti, which talks about exactly that. Thank you. Want me to unmute this?
Yeah. Thank you, Rachel. Why don't we start with any questions or comments from anyone? Maybe we start with people online. One, I'll ask you a question while we're waiting. Two quick questions that I think we've spoken about. One is on pain and pain control, and what has been your experiences with narcotics. And the other question is, how would you see palliative care differ, or the similarities between a place like Gaza and a place like South Sudan, which has many more, let's say, less no, not just less community. I think they have a community, but it's rather less the facilities, not the same sort of, even if Gaza is not as, let's say, as much equipment and trained staff as perhaps other places, it has significantly more than South Sudan.
Yep. Okay. So on opioids and pain relief, I mean, I think it's vastly different all over the world, and there will be some contexts that have very clear legislation that prohibits the procurement or the bringing in of opioids, or policies that restrict opioids. In Gaza, there is no legislature that says that you cannot have morphine or opioids inside Gaza. And it is written into the healthcare system policies that is okay. The biggest stumbling block in Gaza is this extraordinary opiophobia that exists amongst healthcare workers, the system, and community writ large. And that opiophobia, I think, has arisen mainly in the context of young people, particularly young men, experiencing extraordinary chronic pain and suffering from chronic war injuries, particularly very hard to treat neuropathic pain. And so there has become this huge system of black market tramadol and black market gabapentin, and a huge concern that particularly young people are all addicted to chronic pain relief. And so that then precludes the use of morphine and other drugs being used in the context of somebody with a terminal illness. So the two are all mashed together. When I visited Jean in the hospital and asked them, do you have any morphine? They said, they were taken aback and said, oh gosh, we can't talk about morphine here. Yes, we have it in this hospital, but it's only for the surgery department. So it's just not understood as something which can be used across all types of illness and suffering. So opiophobia is a big thing, as well as legislation and policies, but I think it's different throughout, in every context throughout the world. Different contexts. I think we need local research to understand how those contexts differ. I think even in a system of, extraordinary amounts put into the healthcare system, and the number of humanitarian health organisations working in Gaza, there's still nobody really working on home-based care. There will be local community NGOs that do their best and do kind of piecemeal projects, but they're not connected with the system. So, I think a starting point in any context would be to look at how do you reach the most number of people in need, and what already exists in terms of home-based care in reaching people, and does that fit that context? But I don't know the South Sudan context, so I can't speak to that specifically. Dan, do you have a question?
Yes, hi Rachel, thank you for a superb presentation. I had a question that based on a comment that you had mentioned, that I'd love to get more insight from you about, which is the care for the caregiver concept and the enormous psychosocial challenge, or I can't think of a more difficult, I'm just anecdotally speaking, challenge than doing palliative care in a CHE or other kind of setting such as that. And I was curious about your experiences. Have you or colleagues utilized psychological first aid or other approaches for care for the caregiver aspects? Any insights would be greatly appreciated.
I haven't had direct involvement in implementing anything like that, and there may be others who are listening who have. But what I would say is that all of the healthcare workers I spoke to were crying out for something that provides them with not just self-care approaches, but opportunities to have peer-to-peer support and share with each other to help them navigate those distressing environments. Peer-to-peer support was a huge thing that came up in the Gaza context, not only for patients and family members themselves, but for healthcare workers. They also specifically asked for just, small changes in the physical environment that might help them make their day a little bit better, like making sure they have quiet spaces in which to talk to patients. One even mentioned the importance of bringing flowers into the healthcare clinic just to brighten their day a little. So I think there's lots of small acts that can be done. But I haven't had direct experience myself. I think even in our own resource-rich contexts where we're delivering palliative care, we're not very good at self-care, and we're not very good at looking after each other. I'm a physiotherapist in a palliative care unit in Melbourne, and I don't think there's ever been a time that we have all stopped together as a group and thought about the patient who has died. I do that myself because I think it's really important, but I think the world over, we're not very good at that self-care for each other, working in palliative care, and magnify that distress a billionfold in a humanitarian context. I think it's something that we really need to be prioritising. There was one healthcare worker who very emphatically said, how can you ask me to deliver this compassionate care when nobody is taking care of me? Yeah, so I think it's something we need to explore. Thanks, Dan. Megan?
Hi, Rachel. Thank you so much for your presentation. It was really touching and I really appreciate your work. I find many overlaps in the work that I'm doing now, looking at quality of care of maternal newborn health and also mortality surveillance systems. I was curious if you could share any findings from the Gaza context related to perceptions of palliative care for maternal and newborn that are in the process of passing.
Yeah, thanks, Megan. Great question. I did speak to a number of clinicians working in both neonatal ICU and pediatric ICU. I didn't speak to any working in maternal health. And, you know, the people working in those intensive care units, one whose story I shared about her experiences with all those deaths on the ward on one day, we're offering beautiful palliative care in the absence of all of the medicines that they might like. They had done things like learnt about kangaroo mother care, for example, in training programs in the West Bank and in Israel, and have brought that back into Gaza, and we're promoting kangaroo mother care in the neonatal intensive care unit. They were bringing things in like making sure that you know, mothers had unrestricted time with their babies to the extent that they could. Where palliative care seemed to fall down though really was with children with severe disabilities and genetic and metabolic conditions who were, if they were then sent home, the family was then left to care and tend for that child completely on their own. And the story of one mother who herself had breast cancer, so she was both a patient and a bereaved family member, talking about her child who died of a congenital liver disease in her arms at home without any presence of any healthcare worker anywhere in sight. So it certainly came up as an area of interest and of importance for people, but obviously not being done in any protocoled kind of way. Yes.
So I was wondering about cross-country comparisons where I think of programs that had a lot of well-funded programs for HIV/AIDS.
Yeah.
And then prior to ART, I think there was a lot of work on hospice care or home care and alleviating suffering. Then the ART program came in and there was less of people at that, you know, in the dying phase, and had very good, you know, I think that a huge increase, at least around HIV in diagnostic systems, drug supply chain improvements, so that you actually had the potential, you actually had mechanisms develop or structures developed that could do both a medical, potentially in a home-based or community-based setting. So I wonder if there's some variations, if that's, you know, if there's any literature on that.
Yeah.
But then I also found, you know, in some of my experiences, even when you had the treatment available, there was still the stigma around the opioids, and potentially stigma for the health workers to use them. I think in the U.S. Western country with a lot of addiction to opioids, there's almost a stigma to using them, and people are suffering that probably don't need to be suffering here.
Yep.
Because of that backlash against Oxycontin and other things. So there may be even in these countries have all these structures and systems, the stigma still might be there, or I don't know.
And I think that stigma translates from here to there. There was an example not that long ago of a couple of healthcare workers, I can't remember, they were pharmacists from the US who advocated to WHO to remove guidelines around the provision of narcotics, two guidelines, one for adults, one for pediatrics. And WHO did remove those guidelines out of concern that these pharmacists had raised around opiophobia. And so I think that stigma then trickles. So the global palliative care people were saying, you can't remove these guidelines, these are so important, we need them. So I think that stigma does trickle across other countries. And I think it's going to look different in every context. I mean, Gaza is a very particular thing around chronic overuse of tramadol for severe neuropathic pain. I think there's enormous lessons we could learn from HIV. I don't think anyone's pulled together that literature or research, although I'm not sure.
I mean, it was a big issue for the clinical HIV staff here.
Yeah.
Issue of palliative care and being strongly supportive when everyone else was kind of against, or at least on the medical.
Yeah, and I'm sure there's a huge amount that we could learn from people. So, I mean, really the current literature that tries to bring palliative care together with humanitarian response really only started, so Ebola brought it to the fore in a big way, West Africa Ebola. And before that, it was things like Hurricane Katrina and Haiti, 2010 Haiti earthquake, where, there were very public examples of having to choose patients, having to choose who would live and who would die. So those kind of really intense ethical dilemmas brought it to the fore. But I think, I'm sure we could go back and ask for lessons from early days of HIV. I don't think anyone's done that.
Yeah, I was just wondering also, does this effort at palliative care maybe could be taken up faster in those settings?
Yeah, absolutely. And, I mean, drug-resistant TB, I'm sure that there would have been things done in those scenarios as well. But no one's written, not that I've seen, haven't seen that written together, that talks about palliative care. So, Jonathan, you were the one I was looking for on the screen. Do you want to add anything about, or ask your question and add anything about HIV?
Was that this Jonathan?
Yes. Hello, Jonathan.
Hi. Thank you. Thank you for just an incredible presentation. I wasn't going to add anything on HIV. Actually, I wanted to go back to the really interesting statement you made at the beginning about how palliative care and humanitarian action share a kind of philosophical origin in the idea of compassion and responsibility. And my reaction to that is that in recent years, like in the last decade or so, there's been much more attention to the idea of palliative care as a human right, not just a matter of compassion, but something really rooted in human dignity and freedom, in state obligation. UN bodies have recognized the denial of pain treatment as a form of cruel and inhuman treatment, if not torture. There's more and more attention to accountability frameworks around palliative care, the legal obligation of duty bearers to provide it. And I'm just wondering whether and of course, the Lancet Commission on Palliative Care recognizes palliative care within a rights framework, in addition to the public health framework that you mentioned. I'm just wondering whether that framework might have real purchase in humanitarian settings, particularly in places like Gaza, places under occupation, where there is a real consciousness of collective, grave violations of human rights.
Yeah, absolutely. It's in my 100,000 word thesis. I definitely talk about rights in there, just admitted it today. I think there's a challenge though, when you start using rights-based language, and I don't know how to resolve this, so maybe you've got some thoughts, but in a context where there are so many rights violations and so many health rights violations, does talking about palliative care through a rights frame help to further that agenda? I mean, an example in Gaza would be somebody requiring end-of-life care because they haven't had the right to access radiotherapy in Israel. So yeah, I don't know. I think it's worth exploring, and I'd be interested to hear from humanitarian practitioners here as to how that as a narrative flies, but I think I think it's a challenge. Thank you. Caroline. Caroline, are you there and able to? I can't hear you, Caroline, if you're. Okay, yeah.
I have a question. I just wondered, did I understand you right, that a lot of the Palestinian physicians, or at least some of them, didn't feel comfortable providing palliative care, that they didn't feel like they were competent? It was kind of the venue of specialist, was that?
It depended how they viewed it. So those who understood palliative care through a specialist lens would say, yeah, we don't know how to do that, and that's perhaps not our role. We need to bring in specialists, and we need pain specialists, and but for the most part, everybody understood it. Many felt that some of their approaches to care were already akin to palliative care approaches, but they just need more support. And that, things like supporting them with home-based care, making sure that when a patient goes home from hospital, they don't just go into the ether and never to be heard of again. So it was more around putting structures in place to enable them to give that care better. Yeah, it depends how they viewed it. Thank you. All right. Any other? Yes.
Yeah, I'm Coghlan. Thank you for your wonderful presentation. It was really touching and provided me with a lot of perspectives on the palliative care in disputed areas. I'm not really familiar with the issue, but what comes to my mind is that it might be difficult to quantitatively assess the cost and effect of the palliative care provided to the victims of the disputed area and under the humanitarian setting. So is there any tool that can be used to assess the effect and cost of palliative care provided to the victims, as palliative care of the subjects of the palliative care would not really benefit much in aspects of DALI or other normal used in public health. So how should we measure the improvement of quality of life in the patients, and what do you think on the priority and cost of the projects that on palliative care? So that was my question.
Yeah, I mean, so I think there are cost benefit analyses that measures that exist out there, and most of those would be trying to show that with good palliative care you prevent resource intensive, expensive hospital admissions. So in a context like Gaza, you may be able to use such a method, because people in Gaza do end up in emergency in the late hours of dying, seeking help, only to be sent home again. I don't know how you would do that in a context where everything happens at home and all dying happens at home. As I said, it's inevitable that the palliative care is going to involve some resources, right? No matter how basic you make that palliative care, it's still going to cost something. Yeah, so not sure, haven't looked into it. There may be health economists here who know.
Caroline left something in the chat.
Oh, sorry. Caroline, as an ICU nurse, one of the barriers I found was the personal convictions of healthcare providers. Many thought it unethical to move from curative care to palliative care. Wondering if you've encountered such issues in providing care to patients. Yes, thank you, Caroline. Yes, absolutely. I think one of our jobs, though, is to be, advocating to people that it's not an either or. It's a false dichotomy to say curative or palliative care, and that palliative care can be provided alongside curative care in many instances. I mean, in Gaza, certainly there was this tussle between doing every type of medical intervention until the very end, as was happening with my friend Jean, and not giving up on a patient, versus suddenly realizing when a patient is dying and saying we can't do anything more. And I think that, yeah, it depended who you were talking to. I think that both existed in Gaza, as I'm sure it does in many other parts of the world. But yes, certainly a big area for conversation. Any other final comments? I'm aware we've gone way over time. All right, thanks everyone. Thanks for coming.
Thank you, that was very interesting. It was a topic I hadn't heard discussed much, so I appreciate it.
Thanks for coming.
Okay.
Bye, everyone online.
We're gonna go.